Hi, I welcome you to this section. In this section, we'll be discussing fractures, and our focus will be narrowed down to bone and what happens to bone. You know that fractures occur as a result of accident, and accidents happen unplanned, which makes it a non-communicable disease. As such, in this section, we'll be looking at what happens to bones. Bones can be categorized into two primary types based on how they develop during embryonic stages. The first type of bones we're going to consider is the flat bones. That is the bones we found in the skull, the rib bones, and legs. These bones develop through a process called intramembranous ossification. The word ossification means bone formation. So it develops through intramembranous ossification in utero. That's how this bone develop. In this process, a specialized cells known as fibroblasts transform themselves directly into bone cells within clusters of a certain type of connective tissue known as the mesenchymal tissue. And this happens during the early stages of fetal development in utero. So look at here, this is just a diagrammatic representation of this process. It develops from this mesenchyma. This is mesenchymal tissue during embryonic development in utero. So these specialized cells, look at a specialized called the fibroblast, transform themselves into bone cells within clusters of certain types of connective tissue known as the mesenchymal tissue. So from this, it leads to this process. From this becomes a bone. And that is how flat bones, irregular bones, develop during the embryonic development. The next we're going to consider is the second type of bone, known as the long bones. Now, these are the bones we found in the femur, the humerus, the ulna, all those bones that have epiphysis end are known as long bones. These bones develop through a different mechanism called endochondral ossification. Endochondral ossification. This type of bone development starts initially within a cartilage. This cartilage serves as the substrate or the base for the development of these bones. If you look at here, this image here, you would see, okay, a clearer picture. You will see how these bones develop. This is a cartilage. This is when in the utero, that's when at embryological stage, these are cartilage is the major substance that begins the process for long bone. Then bone starts to replace the cartilage. And this cartilage is not a hyaline cartilage model. Then when the bone starts to replace this cartilage, as the baby keep on growing in the uterus, the medullary cavity begins to form, and the growing center of the bone at the epiphyseal region continues until it forms to a full-blown bone, having the epiphyseal plate cartilage where growth occurs, and having the medullary part of the bone that has the blood vessels, Havashan canals, and all of that. And this is where the bone marrow and all of that are formed. So this is the model that long bones follow to grow. It follows the endochondral ossification, while flat and irregular bones follow the intramembranous ossification model. As the bone grows, blood vessels, we're talking about the long bones now. As the bone grows from the cartilaginous model, blood vessels invade the cartilage. Blood vessels begin to invade this cartilage, bringing in cells known as osteoprogenitor cells. These are the osteoprogenitor cells here, which plays a critical role in the bone formation. This inversion leads to the gradual replacement of cartilage with bone. This cartilage is now replaced with this bone. The process occurs at specific area called the center of ossification. This is known as center of ossification, where these osteoprogenitor cells are first deposited. Is known as center of ossification, which are located both in the middle and at the ends of the bone. It starts here. Look at it. At the ends of the bone, epiphyseal region. It occurs here. It occurs here for growth. It also occurs here, and these are known as center of ossification. At each end of the long bones, a small piece of cartilage known as the growth plate or epiphysis remains. During childhood and adolescence, the growth plate contains cells called chondrocytes. Chondrocytes tells you about cartilage, cartilaginous cells. It contains chondrocytes that multiply, allowing for continued growth of the skeleton, like we said earlier. However, when the child reaches puberty, there is a surge in sex hormone that signals a stop to cell division in this region. Subsequently, the cartilage remains diminished and the epiphysis fuses with the main bone structure, stopping further longitudinal growth of this bone. So when the person reaches adolescent, this part of the bone no longer grows. It fuses with the main bone. So that is why we say certain hormones affect bone growth. Okay. So that's what happens in puberty. So we have been able to look at types of bone, how they develop. Look at the flat bones, irregular bones, sesamoid bones that develop from intramembranous. Their model. They will look at the ones that develop through the cartilaginous model, the chondrocytes, the long bones. Now let's look at types of bones tissues we have. In a bone, there are two types of tissues found in a bone, in a normal skeleton. One is the contical bone. Is either you call it the contical bone or you call it the compact. Look at it here. Then you call it the contical bone or you call it the compact bone. It is this part of the bone that you see. It covers the inner part of the bone. And this contical bone or the compact bone is formed from the Haversian system. I will show you Haversian system in the next slide. It's formed from the Haversian system, comprising concentric lamellae of bone tissues surrounding a central canal that contains the blood vessels. Look at the central canal that contains the blood vessels. The central canal that contains this blood. See the blood vessels here. And this is the Haversian canal. This is the Haversian what? Haversian system. And here you find the lamellae and the blood vessels. So the compact bones surround this Haversian system and the lamellae and the central canals that contains the blood vessels. You know, the bone has a very rich supply of the blood. Look at the blood vessels here in the what? Haversian system and the lamellae of the bone tissue. It forms a hard envelope around the long bones. It is the outer part that covers the bone. That is the contical bone or the compact part of the bones. Another type of bone tissue you find in the bone is the trabecular or cancellous bone. Call it trabecular or cancellous bone. This bone fills the center of the bone and consists of an interconnecting meshwork of trabeculae separated by space filled with bone marrow. Bone marrow. This is the spongy bone. Is that you call it cancellous bone or spongy bone or trabecular? So this is the spongy bone or the cancellous bone. It has the bone marrow. Look at the bone marrow here. But from here, down here is the compact bone. Then in between here, I find the Havasian systems and the lamellae that contains the blood vessels. But one remove this is the bone marrow, and it is the spongy bone that surrounds the bone marrow. This is the Havasian systems and the lamellae and the blood vessels. And inside of it, it's covering the spongy bone or the cancellous bone. Then this cancellous bone surrounds the bone marrow that produces all the hematopoietic cells. This is where the red blood cells and the white blood cells are produced. Mainly red blood cells, platelets, and all other cells that are responsible for one of function or the other in the circulatory system. So these are the two tissues we found in the bone, the cortical bone, also known as a compact bone, and the trabecular or cancellous bone or spongy bone. Now let's look at cells that are relevant for us to understand what happens in fracture and how fracture heals. That's the that's the major thing for this section. That is the major thing for this section we need to get from this particular section. I'll talk about the osteoclasts. Osteoclasts are multinucleated cells of hematopoietic origin. They are responsible for bone resorption. When you say resorption, bone dissolving. Then you have the osteoblasts. The osteoblasts are mononuclear cells that are derived from the bone marrow. And they are responsible for bone formation. The bone marrow is the one that produces this osteoblast. And it is the spongy cell that surrounds the bone marrow. Now, osteocytes. Osteocytes are also a group of cells that differentiate themselves. That is, they move, their main origin is osteoblast, but they differentiate from osteoblasts, and now they become embedded in the bone matrix during bone formation. They are responsible for sensing and responding to mechanical stimuli and for coordinating osteoclast and osteoblast activity. That's in the osteocyte, the main bone cells. Osteoclast destroys by way of resorption. Osteoblast build. Then osteoblasts differentiate to become osteocytes in order to coordinate bone matrix, bone formation, and all of that. Then we have the bone marrow stromal cells. These are cells that produce the receptor activator of nuclear factor kappa B ligand and macrophage colony stimulating factor MCS, CSF, which stimulates osteoclast formation and other cytokines that support hematopoiesis. So this particular group of cells coordinates this process, because for production of all these hematopoietic cells undergoes series of processes. It is the responsibility of this cell to coordinate that. Then we have lastly the bone lining cells. These are flat cells lining the bone surface that differentiate from osteoblast when bone formation is complete. So during bone formation, when the osteoblast is there to build a new bone, some differentiate to become osteocytes, some differentiate to become bone lining cells. Now let's look at bone matrix and mineral. Now this is what is known as the Havasian system. From here to this end is known as the compact what tissue of the bone. It has the Havasian system and the blood vessels are found. Then when you move from here inwards, you begin to find the spongy part of the bone. And this is the Havasian canals, okay? Allows blood vessels to move in. And look at the osteocytes being embedded in the bone matrix. And it is this part, the compact bone, that gives the bone its rigidity. So that is why you find the osteocytes here. That is the major part of the bone that gives it its tensile strength and all of that. Whereas the spongy part has that sponginess that allows the hematopoietic tissues to form and to carry out the functions of a hematopoiesis. The most abundant protein of the bone is type 1 collagen, which is formed from 2 alpha peptide chain and 1 alpha 2 chain wounded together in a triple helix. Type 1 collagen is proteolytical. It is proteolytically processed inside the cell before being laid down in the intracellular space, releasing propeptide fragments that can be used as biochemical markers of bone formation. Subsequently, the collagen fibrins becomes cross-linked to one another by pyridinium molecules through a process that enhances bone strength. When the bone is broken down by the osteoclast, that cross links are released into the circulation. And when you do some biochemical analysis of the blood, you might find, if you find this much in the blood, it tells that actually there's an ongoing bone destruction, maybe for whatever reason unknown. So what this trying to talk about is talk about the bone matrix. The bone matrix and the minerals are what give the bone its strength. The bone matrix and the minerals, the calcium, phosphate, is what give the bone its strength. So if there is no cross link, the bone will not be strong. If you look at here now, this particular bone, this Havasian system and the canal, it what give the bone its strength. It what give the bone its strength. So if there's no cross link between the fibrins, the collagen, type 1 collagen, and all of that, the bone matrix will not be strong enough. Therefore, the bone might be very weak. Now, look at what this is, the diagrammatic representation. Look at what we're talking about here. Now, looking at this bone, this is a bone matrix. You see that this is not in right order, and this is the worst case scenario here. This type of bone that is formed this way will not have a very a high tensile strength. As such, may be prone to weaknesses and can break easily. He said that bone is normally laid down in an orderly fashion, yes, like we saw in the last slide, in the orderly fashion. But when bone's turnover is high, that is, when the bone turnover is high, such as in Paget diseases or severe hyperparathyroidism, it is now laid down in a chaotic way, in a chaotic pattern, giving rise to woven bone that is mechanically weak. Here now, the bone is too much. There's a lot of bone cells being released. So the pattern that should have been followed is distorted, and the bone is now arranged in a chaotic manner. And this leads to kind of what you are seeing here as woven bone. This type of woven, this is even the worst. This type of woven bone is mechanically weak. So for whatever that destabilizes the homeostasis, that maintains the adequate amount of bones and other substance and mineralization that will give the bone its strength, would lead to this type of woven bone. And this type of bone is usually weak. Bone matrix also contains growth factors, other structural proteins, and proteoglycans. All of these were thought to be involved in helping bone cells attach to bone matrix and in regulating bone cell activity. The other major component of bone is minerals. mostly calcium and phosphate crystals, which are deposited between the collagen fibrins in the form of hydroxyapatite. Mineralization is essential for bone's rigidity and strength, but over-mineralization causes the bone to become brittle, easily breaks. In clinical practice, increased mineralization can occur in some types of osteogenesis imperfecta, a condition known as osteogenesis imperfecta, where there is excessive mineralization of the bone. So what we're trying to discuss on this bone matrix is that this is the major thing that gives the bone its strength. The minerals, the bone collagens, the bone collagen type 1, the collagen type 1, and other substances, the collagen fibrins, and the pyridinium molecules. They cross-link with each other to form the bone matrix. Then with mineralization, the bone matrix becomes solidified. But where there is excessive production of these substances, it will either excessive mineralization leads the bone to be brittle in condition known as osteogenesis imperfecta, or due to excessive production of bone, the bone is, that is the osteoblast, is much. It leads to Paget disease. Or when there's severe hyperparathyroidism, whereby there's overproduction of the parathyroid hormone, it will lead to a chaotic pattern of the bone matrix formation, which becomes woven, and this is abnormal. Now let's look at fracture. A fracture is a disruption in the continuity of a bone or cartilage. It represents an acute injury that compromises the structural integrity of skeletal tissue and can vary significantly in appearance, including the force applied, the nature of the bone tissue, and pre-existing conditions. There are some conditions that would, that let's say a patient that's having osteogenesis imperfecta, where there's excessive mineralization. And you know that when, like we said, that patients who have osteogenesis imperfecta, the bones are usually brittle. When the person has fracture, the bones will break into pieces. That's why we say pre-existing conditions. There are also other conditions like diabetes and all of that might likely affect the type of fracture the patient might likely have. So this is an example of a fracture of the tibia and the fibula, complete fracture of the tibia and the fibula. Now let's classify fractures. Fractures can be classified based on skin integrity. At first, we have the closed fracture. In this type of fracture, the bone is broken, but the skin remains intact. There's no exposure of the bone to the external environment. This type of fracture reduces the risk of infection. Then we have the open fracture, also known as compound fracture. The broken bone is seen outside, like you can see here. Like you can see here, it's seen outside, and this requires prompt medical attention because of bleeding, infection, and all of that. Then let's also classify fracture based on fracture pattern. We have the transverse fracture. This type of fracture has a horizontal fracture line occurring perpendicularly to the long axis of the bone. It's typically caused by a direct force of trauma. This is transverse. It cuts this way, in a transverse way. It cuts this way. This is a transverse fracture. An oblique fracture cuts this way. See, it's an oblique fracture. It's an oblique fracture. Then you have the spiral fracture. A spiral fracture is bit a helical pattern. Look at what happened here. Look at how it's now this one broke. It's a spiral fracture, and usually from forces rotational forces. Then another type is the comminuted fracture. This involves the bone being broken into multiple fragments. And this type of fracture often results from severe trauma, leading to complications in healing. If you look at here now, you'll see that this bone broke into pieces a lot. Mostly, we could refer that the bone is breakthrough. So that is comminuted what? Fracture. Then another form, based on the classification on skin integrity, we'll talk about the green stick fracture. Sorry, not based on skin integrity, please. We are discussing classification of fracture based on fracture pattern. We are done with skin integrity, where we talk about open and close. Now we are talking about classification based on fracture pattern. And we've looked at transverse, we've looked at oblique fracture, we've looked at spiral fracture, we've looked at comminuted fracture, we looked at green stick fracture. And we'll say that it's an incomplete fracture that occurs in children where one side of the bone is broken while the other side bends. This mimics the way of a small tree branch break. So if you look at this bone here, broke but didn't cut through. A green stick fracture. Then let's also classify fracture based on the location. Which part of the bone did the fracture occur? This is epiphysis and this is diaphysis. So if it occurs on the shaft, that's this type of fracture. Then if it occurs here, it's epiphyseal fracture. So look at the breakage here at the epiphyseal region where growth of the bone do occur. Now let's look at bone remodeling. Bone remodeling. Now, when fracture have occurred, the next is the healing of the bone, and that is known as bone remodeling. Bone is renewed and repaired by the process of bone remodeling. What is bone remodeling? Bone remodeling is like cleaning and repair job for your bones. Just like you might fix or repaint a wall in your house when it gets old or damaged. Our bones also need to be fixed and renewed over time. This makes sure that our bones are very strong and healthy. And this picture is a diagrammatic representation of what happens during bone remodeling. And you can see here, this is the bone, this is the bone, and this is the osteoblast forming bone here. And this is the osteoclast dissolving, bone resorting by osteoclast, dissolving the bone here. And then the osteoblast forming it and sealing it. Signs and symptoms of fracture. We have pain, swelling, bruising, deformity, loss of function, crepe tooth. Crepe tooth is a sound that as the bones scratch against each other, you hear the crepe tooth sound. The numbing or tingling sensation. These are classical signs of fracture. Let's now proceed to the bone remodeling proper. We've looked at the introductory part of what happens in bone remodeling. How does bone remodeling happen? It has stages. The first stage is known as quiescence or resting phase. In this phase, the bone is not changing much. It's not doing anything. It's just sitting there waiting for the signal to start working. That's the first stage. The next stage is resorption. That is taking away, dissolving. The first job is to clean up any old or damaged part of the bone. Let's say someone had a fracture. So it is the first thing to be done. That's bone resorption. So for this to happen, there are a group of cells known as osteoclasts, like we said earlier. They are the ones that demolish that destroyed bone or broken bone at the edges of the bone. They remove the damaged part of the bone. That is what is happening here. This part of the bone damaged. osteoclast now is trying to work on it, removing those damaged what? Bone particles. So remodeling starts with the attraction of the osteoclast precursors in the peripheral blood. So there are a lot of stages that happen that need to attract this osteoclast from the blood to the site of the bone. And this is mostly carried out by release of what is known as chemostatic factors. These are, it could be interleukin, it could be a lot of mediators that once it's being released in the blood, osteoclasts know, we are needed here to go and do some work on the bone. They will move to that area. And that's not chemostatic movement. So the osteoclasts go to that place, that damaged old bone area, and break it down, just like removing old bricks from a crumbling wall. This process takes about 10 days for it to remove the damaged bone cells and old bone. After this stage of resumption, the next stage is reversal, or preparing to build the bone. After the osteoclasts are done with the job of taking away the bad part of the bone, they don't stay around. They die off through a process known as a programmed cell death, apoptosis. They die after they are done doing their work of removing the old and bad bone for 10 days. They die. Then that leads to the next stage known as formation stage, or building new bone. At this point, the osteoblasts, who are the actual bone builders, are then attracted. They begin to make new bone in that area that have been removed of dead bone cells, damaged bone cells. The osteoblast starts filling in the gaps left by the osteoclast. That is what happens here. All that have been left up by the osteoblast begin to fill it up. They build new bones materials called osteoids. These osteoids are soft and they are not yet hard like the real bone. These are osteoids. You see, it's different from the main bones. But over time, these new bones get harder because they are now mineralized with calcium and phosphates. As such, this makes them what? Strong and mature. So when the calcium and phosphate are now added to the bone matrix of the osteoids become strong and matured. That is why if you have seen patients who undergo bone surgery and all of that, they are given a certain time before they can start using their leg to touch the ground gradually and all of that. So after the osteoblasts are done producing the osteoids to cover the space created by the osteoclasts, what happens to the builders or this osteoblast? Some of the osteoblasts get stuck into the bone themselves. And now they now turn into what is known as osteocytes. Remember, osteocytes, like I said, there are cells that differentiated from osteoblasts. So they now turn into osteocytes. Now, these cells, like we were told earlier, act like supervisors and help control what needs to be done next in that new bone. You see, so that the bone matrix will be strong and able to do the work necessary. So that is the function of these differentiated osteoblasts, known as osteocytes. Why some differentiate to osteocytes, some differentiate to bone lining cells. And these bone lining cells, like we are told, are the cells found at the outer part of the bone, the already healed bone. And these bone lining cells helps protect the strong bone structure. So that is what happened in the bone remodeling. After this remodeling of the bone, remember, it has stages. At first, inflammation will occur because there is a disruption. That inflammation will carry mediators that will now attract osteoclasts. When there's a damaged bone, inflammation will occur. Fighters will go there to fight infections that have entered through the opening of the wound. As they are going there, mediators that will attract the bone destroyers, known as osteoclasts, will also be released in the blood, and the osteoclast comes there. Once osteoclast comes there, they start to do bone resorption. After bone resorption, osteoblasts will start their work, reversal and bone formation. From after they are done with bone formation, the osteoblasts differentiate into osteocytes and bone lining cells. The next is to mineralize by the supervision of the osteocyte. So therefore, the mineralization of bone is important to help the bone mass to be strong enough. So mineralization of bone is critically dependent on the enzyme known as alkaline phosphate, ALP, which is produced by osteoblast, and degrade pyrophosphate, which is an inhibitor of mineralization. The pyrophosphate, recall in the previous section, is responsible for formation of crystals, and yet it is an inhibitor to the mineralization of cells of this of the bone matrix. Sorry. So the release of this enzyme alkaline phosphatase helps in the mineralization of the bone and inhibition of pyrophosphate. So therefore, bone remodeling is predominantly regulated at local level. It's important we know that. Let's say a fracture occurred in your hand, one of the fingers, bones. Everything that's happening there is just within that local part. Other part of the body might not be aware. But however, it is important to know that certain circulating hormones in the body or mechanical loading can regulate or downgrade the remodeling across the whole skeleton. What this means is that normally, if there's a fracture in a particular bone, the bone around that place will trigger this process of bone remodeling. But however, if there's excessive circulation of a particular hormone, like estrogen that we know that inhibit bone growth, it might likely affect it. Or other hormones or over-mineralization can also either upgrade the rate of the bone healing or downgrade the rate of the bone remodeling. That's what it's trying to let us know. So there are factors that affect what bone remodeling or healing. Now, the mediators that can be in the blood that can either downgrade or upgrade the remodeling process include mediators like the parathyroid hormone, which is being produced by the parathyroid gland. This hormone increases bone resorption and formation. So once this hormone is there, bone building processes, remodeling process is enhanced. You have mediators like the estrogen, which is produced in the ovary. It inhibits bone resorption. So if there's no bone resorption, then that means bone building will not be possible. So when there's excess circulation of estrogen, it will inhibit bone resorption. Therefore, it affects the osteoclast activity. Then we also have the glucocorticoids produced by adrenal gland. It inhibits bone formation. So some of the external or manufactured or synthesized glucocorticoids are not advised when management of patients with fractures, because they inhibit the bone formation. Management of fracture. Management of fracture involves the following. 1, immobilization. Immobilization is carried out using a splint or a sling to immobilize the affected area and prevent further injury. Just to keep it safe that further injury will not occur. You know already the bone is broken. So as they scratch against each other or rub against each other, it might delay the osteoclast activity and osteoblast formation activity. Osteoid formation. Then elevation. Elevation of the injured part above the level of the heart help to reduce swelling. Then ice application. Application of ice pack can help decrease pain and swelling. Then pain management. This is usually done using over-the-counter drugs such as acetaminophen or ibuprofen to reduce the chances of the pain level. Then avoid weight bearing because the bone is still forming and requires mineralization for it to become strong enough to carry out the functions expected to carry. Then in advanced, do casting in the hospital. You do casting. A casting is a plaster or a fiberglass that is applied to immobilize the fracture site. Then surgical fixation, there's a lot of surgical activities that can be carried out using external fixators, intramedullary nailing, and all of that to bring the bones together. Then rehabilitation. Once the fracture has healed, physical therapy is often necessary to restore function, strength, and range of motion. As such, rehabilitation is important, especially exercise, in order to help the bone become strong. Then follow-up of care. It's usually the duty of community practitioners to follow up patients who have just been discharged from hospital due to fracture. The nutritional support, adequate intake of calcium and vitamin D is important for bone health and healing. So these are the ways we manage fractures in healthcare system. Then some medical evaluation that can be done include x-rays to find out the fracture, how it broke. Like most of the pictures we saw in this section, we're actually taken using this x-rays, MRI, and CT scans. The physical examination is important too to find out other things. Thank you for joining this section. Hope to see you in the next